Let's talk about the drugs which we use for malaria. So malaria is one of the most common diseases worldwide and a leading cause of death. So 4 species of Plasmodium commonly infect humans like Plasmodium falciparum, Plasmodium malariae, Plasmodium ovale, and Plasmodium vivax. And they undergo a primary developmental stage in the liver and then they parasitize erythrocytes. Plasmodium falciparum and Plasmodium malariae have only one cycle of liver cell invasion. Other species have a dormant hepatic stage responsible for recurrent infections and relapses. A 5th species, which is Plasmodium no lesi, has been recognized as a human pathogen, but little is known about it. Primary tissue schizonticides, for example, primaquine, will kill the schizones in the liver, whereas blood schizonticides like chloroquine, artemisinin, and quinine, they will kill I've drawn them here, like this is chloroquine, this is artemisinin, like Artemis, the Greek god, and then it is going to act on the RBCs, and then we also have quinine. They will kill the schizones in the liver, whereas blood schizonticides, chloroquine, artemisinin, quinine will kill those which only are present in the erythrocytes. Then we have sponticides, for example, proguanyl pyrimethamine, and they will prevent sporogony and multiplication in the mosquito by acting on the plasmodium, which is present in the host parasite. Drugs used for the treatment are here shown. Okay, so we have chloroquine. So now let's talk about chloroquine classification. So chloroquine is a 4-aminoquinoline derivative. It is rapidly absorbed when it is given orally, and it is widely distributed to the tissues, and it has an extremely large volume of distribution. It has to be excreted in the urine, and it is excreted and changed in the urine, and antacids are going to decrease the oral absorption of the drug. Now let's talk about the mechanism of action of chloroquine. Chloroquine is going to accumulate in the food vacuole of the plasmodia, and it will prevent the polymerization of hemoglobin breakdown product, which is heme, into hemozoin. So it will lead to the accumulation of heme, which is going to kill the parasite on its own. Intracellular accumulation of heme is toxic to the parasite. Decreased intracellular accumulation through increased activity of membrane transporters is a mechanism of resistance, which is due to a mutation in PFCRT, which is Plasmodium falciparum, chloroquine-resistant transporter. Now let's talk about the clinical use. Chloroquine is a drug of choice for acute attacks of non-falciparum and falciparum malaria and for chemoprophylaxis, except in the regions where Plasmodium falciparum is resistant. Unfortunately, chloroquine resistance is common in many parts of the world. This drug is solely a blood schizonticide. Chloroquine and hydroxychloroquine are also used in autoimmune disorders like rheumatoid arthritis, where we only have to treat the symptoms and not the thing in itself. So in rheumatoid arthritis, it is going to act as an immunomodulator. They have to be shown to be without effect in COVID-19. Now let's talk about chloroquine toxicity. So for that, just remember that it is going to cause GIT distress, skin rashes, headache, and something related to the eyes, something related to the brain, and something related to the ear. So auditory impairment and toxic psychosis, as well as retinal damage. It is also going to cause peripheral neuropathies and toxic psychosis. And the most important thing that I noticed was that it is going to precipitate the porphyria attacks. So when porphyria attacks are going to be precipitated, it is going to lead to what? It is going to lead to peripheral neuropathies. Okay, and myocardial depression as well when the blood is directed into the heart. Now let's talk about another class that we have, which is mainly of artemisinin. So we have that artesunate, which is commonly used in cerebral malaria, and then we have artemether and dihydroartemisinin. Artemisinin is metabolized in the food vacuole of the parasite, forming toxic free radicals. So those free radicals are going to combine with heme, and they are going to actually destroy the mitochondria of the microtubules and the parasite wall. Artemisinins are blood schizonticides. They are active against Plasmodium falciparum, including multi-drug resistant strains. IV form of the artesunate is available for severe infections. They are not used alone in chemoprophylaxis because of the short half-life of 1 to 3 hours. However, they are now considered the first choice for chloroquine-resistant malaria in most of the countries. They are best used in combination with other drugs. They are the only drugs which are reliably effective against quinine-resistant strains. Adverse effects also against chloroquine-resistant strains. Adverse effects are mild, but they include nausea, vomiting, and diarrhea. And artemisinins do not alter rates of congenital abnormalities, stillbirths, and abortion in pregnant women. Now let's talk about another thing, which is quinine. So, quinadrine or quinine. It is rapidly absorbed orally and it is metabolized before renal extraction. Intravenous administration is possible in severe infection, so it is mostly given orally. Now let's talk about the mechanism of action of quinine. So, quinine is going to form a complex with the double-stranded DNA, and it is going to prevent the separation of the strands. So, there is going to be no replication of DNA or no RNA transcription. Quinine is solely a blood schizonticide. The main use of quinine is in Plasmodium falciparum infections resistant to chloroquine in patients who can tolerate the oral treatment. Quinine is commonly used with doxycycline, so it is more toxic than your X because it has to be used with doxycycline or clindamycin to shorten the duration of therapy and limit toxicity. Quinidine, the Quinidine, the dextrorotatory stereoisomer of quinine, is used through IV in the treatment of severe or complicated falciparum malaria. To delay the emergence of malaria, quinine should not be used routinely for prophylaxis. Now let's talk about toxicity of quinine. It has a lot of toxicity. For that, please remember black water fever as well as synconism. Synconism is an umbrella term which is used for GIT distress, headache, vertigo, blurred vision, and tinnitus. Severe overdose will result in disturbances in cardiac conduction as well that resembles quinidine toxicity. Hematotoxic effects will occur including hemolysis in G6PD deficient patients. So this is the most important thing. Hematotoxicity and black water fever as well as synconism. Black water fever is an intravascular hemolysis. It is a rare and sometimes fatal complication in quinine sensitized persons. Quinine is contraindicated in pregnancy. Now let's talk about mefloquine. Mefloquine is a synthetic 4-quinoline derivative. Because of its low, like chloroquine. Okay, because of its local irritation, mefloquine can only be given orally, although it is subject to variable absorption. Mechanism of action is not known. Now let's talk about the clinical use of mefloquine. It is a first-line drug taken weekly, given for prophylaxis in all geographical areas resistance, and it is an alternative drug to quinine and in acute attacks and uncomplicated infections resulting from Plasmodium falciparum. Resistance to mefloquine has emerged in the regions of Southeast Asia. Now let's talk about toxicity. This is going to be GIT distress, skin rash, headache, and dizziness. At high doses, mefloquine can cause cardiac conduction defects, psychiatric disorders, and neurological effects, including seizures. Now let's talk about primaquine and tafenoquine, which were basically tissue cytones which acted on the liver on specific stages of the development. So basically, they are going to be gametocidal, and they are also going to act on another form. I'm going to tell you about that later. Primaquine and tafenoquine, they are synthetic 8-aminoquinolines. Primaquine absorption is complete after oral administration. It is followed by extensive metabolism. Tafenoquine is slowly absorbed. Half-life is about 2 weeks. Tafenoquine is slowly excreted in the urine. Mechanism of action of primaquine is that it is going to form quinoline-quinone metabolites, which are electron-transferring redox compounds that act as cellular oxidants. So they are going to cause oxidative stress. The drug is a tissue schizonticide and also limits the malaria transmission by acting as a gametocide. Tafenoquine will also work similarly. Primaquine and tafenoquine will eradicate liver stages of Plasmodium vivax and Plasmodium ovale, and should not be used in conjunction with. They have to be used in conjunction with the blood schizonticide like chloroquine or quinine. Although it is not effective alone in acute attacks of vivax and ovale malaria, 14-day course of primaquine or single dose of tafenoquine is given after treatment with chloroquine, and the drugs are also used as an alternative daily for primary prevention. Tafenoquine was approved in 2018 as another chemoprophylactic regimen with simplified dosing 200 mg daily for 3 days and then weekly. Now let's talk about the toxicity of primaquine. So primaquine and tafenoquine are usually well tolerated and can cause GIT distress, pruritus, headache, and methemoglobinemia. But the most important thing was that in G6PD deficient patients, they are going to cause hemolysis. Primaquine and tafenoquine are contraindicated in pregnancy. Now let's talk about anti-folate drugs, which are going to inhibit the DHFR or dihydropteroate synthase. Now we have pyrimethamine, proguanyl sulfadoxine, which is a sulfonamide, and dapsone. I don't know where that came from. All these drugs are absorbed orally and are excreted in the urine, partly in unchanged form. Proguanyl has a shorter half-life, 12 to 16 hours, as compared to the others in this class, which have a half-life of more than 100 hours. Now let's talk about the mechanism of action. Sulfonamides will act as an anti-metabolite of paramanobenzoic acid, and they will block the dihydrofolate synthase in certain protozoans. They will inhibit dihydropteroate synthase. Proguanyl is bioactivated to cycloguanyl. Pyrimethamine and cycloguanyl are selective inhibitors of fructose 1 dihydrofolate reductase. Pyrimethamine and proguanyl, or pyrimethamine and cycloguanyl, they are going to be selective inhibitors of DHFR or dihydrofolate reductase. Combination of pyrimethamine and sulfadoxine, which is also known as fancy DAR, has synergistic anti-malarial effects through the sequential blockade of 2 steps in folic acid synthesis. Clinical uses. Antifolates are blood schizonticide which act mainly against Plasmodium falciparum. Pyrimethamine and sulfadoxine or fancy DAR is used in the treatment of chloroquine-resistant forms of the species, although the onset of activity is slow. Proguanyl and atovaquone or malarone can also be given for chemoprophylaxis of chloroquine-resistant malaria, and it is also protective against mefloquine-resistant falciparum strains, specifically for travelers. Toxic effects of sulfonamides will include skin rashes, GIT distress, hemolysis, kidney damage, drug interactions caused by competition for plasmapheresis binding sites. Pyrimethamine will cause folic acid deficiency when used in high doses, so we will have to give folinic acid or vitamin B9 for that. Then we have other anti-malarial drugs like doxycycline, modiaquine, atovaquone, and helofentrine. Doxycycline is basically a tetracycline which binds to the 30th ribosomal subunit and inhibits the protein synthesis. Then we have so doxycycline is a tetracycline. It is chemoprophylactic or taken daily for travelers to geographical area with multi-drug resistant Plasmodium falciparum. It is sometimes used in combination with quinine. it is active in active falciparum infections. Then we have amodiaquine. So amodiaquine has been widely used to treat malaria in many countries because of its low cost and in some geographical areas. Effectiveness against chloroquine-resistant strains of Plasmodium falciparum was there. It is also used in fixed combination with artesunate, which was used in cerebral malaria. Hematological toxicity, including agranulocytosis and aplastic anemia, have been associated with the use of amodiaquine. Then we have atovaquone, which is commonly given in the form of malarone along with proguanil. It appears to disrupt the mitochondrial electron transport in protozoa. Malarone is effective for both chemoprophylaxis or taken daily, and treatment of Plasmodium falciparum abdominal pain and GIT effects occurs at higher doses needed for treatment. Atovaquone is an alternative treatment for pneumocystis cerevisiae infection. Then we have halofantrine. Although its mechanism of action is unknown, the drug is active against erythrocytic but not other stages of all 4 human malaria species, including chloroquine-resistant falciparum. Well, halofantrine is not used for chemoprophylaxis because of its potential for quinidine-like cardiotoxicity or QP prolongation and embryotoxicity. Lumefantrine is a related drug with minimal cardiotoxicity. It is now used in fixed combination with artemether, which is coartem for complicated falciparum malaria in many countries. Then we have the drugs for the prevention of malaria in travelers. Chloroquine remains an appropriate agent for prophylaxis in regions with resistant Plasmodium falciparum, as does mefloquine weekly in regions with Plasmodium falciparum resistance to chloroquine. In areas with multi-drug resistant malaria, the choice is either going to be doxycycline or atovaquone plus proguanil, which was malarone. Both drugs must be taken daily. Primaquine, which is going to be taken daily for 14 days, or tafenoquine, which is going to be given as the single dose, is recommended for general prophylaxis of Plasmodium vivax and Plasmodium vivax infections, and is an alternative in primary prevention.